participants. Good evening from Dr. Amarjit Singh, a part of the Wockhardt medical team. It is with great pleasure and honor that we welcome you all to the iTrust webinar on the topic of paramount importance, that is uncontrolled diabetes and pill burden. We are truly privileged to have a renowned expert in the field, Dr. Sajid. He will here with us. Sir will share his insights and knowledge on this critical subject. Throughout this webinar, Sir will be shedding light on the challenges faced by the individuals dealing with the uncontrolled diabetes, as well as the burden that comes with managing the multiple medications. Dr. Sajid, he is the director and medical consultant from Mitra Medical Center, Thrissur, Kerala. Sir has done his MBBS from Government Medical College from Thrissur, and Sir has done his MD in General Medicine from Government Medical College, Calicut. Sir has 5 years experience in Kerala Health Services as consultant physician, 12-year experience in Ministry of Health, Saudi Arabia as a specialist in internal medicine. And Sir has very in-depth interest in diabetes mellitus. So we have an opportunity to hear from Dr. Sajid. So now we'll not take any of minute of you. So we will ask Sir, Dr. Sajid Sir, to start the webinar. So over to you, Sir.
Okay, thank you, Dr. Amarjit.
Yes,
can I share my screen now?
Yes, sir. I stopped sharing. Now you can try, sir. Share screen you will find somewhere in the green spot.
Yeah.
Yeah, it is visible, sir, now.
Visible now?
Yes, sir.
Yeah. Slide is visible now?
Yes, sir. But put on the presentation mode, sir.
Presentation?
Presentation mode, sir. In the right side, you will find the presentation mode.
Presentation on the right side?
Right side downward, sir. Corner. The cup shape structure you will find, sir. One logo cup shape. Just click on that.
Sir, that 57% is written, no, sir? On the right hand or right side of that 57%.
Yeah, where the 57% written in the down.
This is the one?
57% could you find, sir? And the right side down corner.
This one?
No, sir. 57% because I am not able to see. Please move your cursor, sir.
Yeah. Can see?
No. Sir, minus plus is there in the right side corner downward. Minus plus 57% at the corner.
You are seeing my screen, no?
I can see, but I am not able to see the cursor, sir. Yours.
This one? Resize.
Slideshow will be shown, sir.
The
Slideshow.
cup shape structure, sir. Just left side of 57%. You will see a cup type structure. Click on that, sir.
This one?
Click it, sir.
Huh?
Because we are not able to see the cursor. Just left to the 57%. Whatever the logo you are watching, just click on that, sir.
57%.
Shall I share my slide and I will show you, sir?
Yeah, 1 minute. 57%, where is it?
It's the right side.
Downside, sir, downside, bottom side.
Downside, bottom.
Right side.
Right.
Downside, sir. Right and down. Corner side. Down corner, right side.
Down and corner. Right. Huh? Stop share. Optimize video. I think I'm not seeing any 57% here. So what to do
Okay.
now?
Sir, I will just show you. Sir, could you stop sharing?
Okay.
Okay. So, sir, just I'm sharing my slide and
Yeah.
that you can see that. I shared it. So it is in the presentation mode. I will just remove it.
Nara? Hello.
One moment. So here, sir, you can see this in right side where my cursor is here. This here you have to click, sir. This cup side.
Yeah.
Cup side. Got it, sir?
Hello.
Yes, sir.
Ah.
So I will just click here.
Meeting.
So once I clicked, it came on the presentation mode, sir.
Popular.
So you want to share, sir, or shall we go ahead with this only?
So I'll take my slide and.
Okay. I will just stop sharing. You try, sir.
So okay.
Okay.
I'll click on share screen.
Yes.
Right.
Sir. Yes, sir.
Okay.
Yes.
Now here, this one, no?
Yes, sir. Yes, sir. We can see it. Double click.
Now I am.
Click it.
Okay.
Click double.
Okay,
not in the presentation mode. Click double, sir. It will spread to the entire screen.
Earlier it came actually.
No, that's why you click again, sir. Double click there.
Yeah, we need to double click or single click?
Double click quickly.
Single click, sir.
Double click. Okay, I'll do again.
If single click is not working, then try single click. Single click first.
Participant, you can see now?
We can see, sir, but not in the presentation
Sir,
mode.
sir, that resume slideshow is there on the top.
Slideshow.
Resume slideshow is written on the top, sir. You can see.
Resume slides.
If you can press on that.
Resume slideshow.
On the top it is showing, sir.
Slideshow.
Or sir, shall I share for you, sir?
Resume slideshow.
Yeah, I think it will come now.
Okay now?
1 second.
Okay, go on.
Sir, do enable editing.
Enable what?
Enable editing, that the yellow color band is there, protected view. In the middle of the upper side, enable editing, it is written. Maybe
Enable
from
what?
there.
Enable what?
Editing.
Sir, that yellow color bar is there on upper side on slide.
Just above the iTrust in the upper side.
iTrust. Enable editing.
Yellow color bar, sir, band.
Enable editing is written, sir. If you can click on that.
In the center of the upper side, sir. Sir, shall I share for you, sir, the slides from my side only?
When you will share, I'll read from here.
Yes, sir. And you will say next slide, I will move. Sir.
Okay. We'll do like that. Okay.
Okay. Stop sharing, sir, from your side.
Okay. Okay.
The slide is visible now.
Yeah. Please make it full screen.
Yeah. So from here, sir, the slide is begins.
So we'll start now.
Yes, sir.
Okay. So good evening, everybody. I'm Dr. Sajid. Sorry for the technical issues. So today we are focusing on multiple drug and the drug load for control of diabetes. So as you are aware, the compliance with medication is a very important factor for the diabetic control. So this is the slide showing which aspects are contributing to the behavioral patterns of glycemic control. Here they have analyzed general diet, specific diet, exercise, SMBG, medications. So you can see only the medications, the only medication adherence was significantly associated with lower HbA1c after adjusting other self-care behaviors and further adjusting demographic and diabetic characteristics. So all the others, we cannot make any significant contribution towards controlling HbA1c in this. So we have to focus on medication and the adherence. Medication adherence is the most important self-care behavior for glycemic control among adults with T2DM, especially in low SCS group. Okay, next slide, please. Yeah, adherence rate for oral agents are less than 50%. Although medication adherence is one of the most important self-care behavior, but more than 50% remain non-adherent despite they being on oral agents. This is the first year follow-up in orange, and green is in the 2-year follow-up. You can see by the end of 2 year, most people are not adherent as when they are starting. Next slide. So this is the slide showing impact of poor adherence to glucose lowering agents. So as you can see, the overall, there is 73% increased risk of all-cause mortality due to poor adherence to oral hypoglycemic. This is simple logic because lack of control in diabetes is the key that leads to complications. You see more than 80% poor adherence, it is probability of hospitalization is 37 only. But when the compliance is less than 20, you see the hospitalization is rising to 56%. So, next slide. So, why this is happening? What are we missing? Maybe forgetfulness, maybe disorganized behavior. So the solution is that we need to address all these problems to improve the adherence of people. Next slide. Yeah. This is the factors that leads to poor compliance from the patient side. Patients, they think that the treatment is not efficient. They will go to measure their weight. They will see, oh, it's not improving. So they discard the medicine. They're thinking it is not useful. And other factors when they consider are adverse effects of the drug, long-term adverse effects, especially when people of alternate medicine, they talk many things about modern medicine without knowing the basics. And people fall into these traps. And using a medicine represents a sickness on the part of patient. No? So they don't like to take medicines regularly because that makes them appear they are very ill people. So they tend to stop when they feel improvement in their illness. Then the perceived benefits, it is rarely apparent. As you know, when you are controlling diabetes very well, the patient may not feel it right there. The benefits are accruing over time only. Maybe after 5 years, there will be benefits. But in the present state, patient is not feeling. So he is not concerned about adherence so much. And healthcare practitioners may state that long-term risks are reduced, but patient may not believe all those things. So perceived worthwhileness of the drug. Does the patient believe the benefits of medication outweigh cost? That is also important. Patient should feel that whenever they are spending money, they should be getting benefits out of that. No? So it's our duty to educate them and make them more compliant. Okay, next slide. So we are going to the basics of fixed drug combination now. Fixed drug combination, as you know, is one of the best way to improve adherence in the medicine and reduce the drug load in difficult to control diabetes. So what is the need of the FDCs? FDCs, progressive nature of diabetes mellitus, usually it will cause insufficient glycemic control in patient on monotherapy over a long period of time. Because we know diabetes is not a single factor problem. It is coming due to many pathological changes in our body. So it needs multiple drugs, not a single drug can take care of all the issues in diabetes. So this necessitates the requirement of additional agents for achieving desired glycemic control. Use of combination drug is common in the management of type 2 diabetes to achieve those. Fixed drug combination with single pill formulation of 2 or more drugs are widely used for effective glycemic control in the management of diabetes, as it makes easy for patient to comply with the doctor's prescription. Next slide. So we are selecting the components of FDCs based on three important aspects. The drug in combination should have different mechanism of action. Pharmacokinetics must not be too different from each other. Combination should not have additives that can induce toxicity. The combination can be chosen based on recommendation of treatment guidelines, whether guidelines support its use or have raised any concern. So the drugs should be compliant with the guidelines. Next. So these are the merits of fixed drug combination. Simple dosage improves the therapy adherence, reduced pill burden, reduced medication error. It allows drugs with synergistic combination and low manufacturing costs, simplified dosing with only one expiry date. So these are the merits of FDCs, but we should also be aware of the demerits of FDCs. No dosing flexibility, risk of drug interaction leading to altered therapeutic effect, incompatible pharmacokinetics of individual components. If the FDC is irrational, it can happen. Need to discontinue if patient is allergic to even one of the components. So that is also a problem. FDCs may sometimes become expensive than single dose tablet. So you have to go for separate drugs in such a case. In India, many clinicians recommend patients newly diagnosed with T2DM to start with FDC for their multiple advantages. Okay, next slide. So we are selecting the drugs based on patient profile. This is a ABCD approach. A is age. Younger patient may benefit from lower HbA1c targets. So maybe we have to be more aggressive with younger patients. Body weight, choose the drug that enhance weight loss in patients with excess weight. Complications. Comorbidities are the main thing we consider when we select a drug. People with comorbidities such as CKD or CVD or who are susceptible to hypoglycemia may benefit from glucose lowering drug with established safety and efficacy profile. So the next thing we consider is duration. People with longer duration of disease, they may need treatment adjustment, and even they may need insulin along with their disease. Next slide. So the recommendation for using combination in T2DMR, this is from IDF for the dual and triple drug therapy. Initially, we know we are all using metformin. So if the patient is on metformin, second glucose lowering drug should be added if monotherapy with metformin is not sufficiently effective to reach HbA1c target. Then the best choice is to add sulfonylurea except glibenclamide, or a DPP4 inhibitor, or a SGLT2 inhibitor. We can add alpha glucosidase inhibitor also. A GLP-1 receptor agonist can also be used if a patient can afford it. Next slide. So the recommendation for using combination therapy in T2DM continuing. This is from ADA 2020. If the glycated HbA1c target is not achieved after 3 months and the patient does not have ASCVD or CKD or heart failure, so we need to consider combination therapy in such patient. The combination of metformin and any one of the following preferred medicines can be considered. We can consider sulfonylurea, thiazolidinedione, DPP4, SGLT2, or GLP-1, or basal insulin. T2DM with established CVD regimen should consist of SGLT2 inhibitor or GLP-1 receptor antagonist. GLP receptor agonist with demonstrated CVD benefit. However, it should be done after evaluating drug-specific and patient-related factors. You can see GLP-1 receptor agonist. Usually it is very costly. So the first choice automatically goes to SGLT2 inhibitor as the second line. Okay, next slide. So RSHGI 2020 recommendation for second line therapy. We need a patient-centric approach. If glucose target are not achieved, we need to add SU, thiazolidinedione, or SGLT2, or DPP4, or AGA. So this we individualize according to the comorbidity of the patient. Next slide, please. So what are the unmet medical needs in T2DM? We are not dealing with glucose only. We are dealing with multiple issues in diabetes, especially in patients with cardiovascular risk factors. We are dealing with many other factors. So the factors a need for combination approach to address multiple pathophysiological mechanisms of hyperglycemia to achieve robust glycemic control. A need for additional treatment that provides both glycemic and non-glycemic benefits, like the benefits on atherosclerosis, benefits on kidney function, benefits on heart function. So these are all should be considered. Reducing the occurrence of hypoglycemia or weight gain as a recurrent distressing side effect of traditional anti-diabetic agents reduces the morale of not only patients but also the treating physician. So if a patient is having frequent hypoglycemia or if he is experiencing heavy weight gain, automatically he will drop off from the treatment. So we need to focus on that. An oral treatment option is not only meet all the pressing need, but additionally improve the compliance of patient in need. We should give patients such an option, oral treatment option that not only meets pressing needs, but additionally improves the compliance. So we need to reduce the drug load. Next slide, please. So this is one of the best example of complementary glucose lowering activities when we are choosing FDCs. So the latest combination we are using SGLT2 inhibitor and DPP4 inhibitor. This combination is having very good acceptance among the clinicians as well as the patients. So we will analyze why this is a preferred combination. SGLT2 inhibitor, as we know, the mechanism of action increasing glycosuria, beta cell sensitivity increasing, and increases the glucagon also. But DPP4 inhibitor, as you see, it reduces the glucagon level. It increases the insulin secretion. It is having incretin effect. So the combination of these two, it can lead on to better reduction in hyperglycemia. SGLT2 inhibitor, it will take care of BP and it can induce weight loss also. Whereas this DPP4, it is weight neutral. So it will not cause weight gain. Whereas SGLT2 inhibitor can lead on to weight loss also. But SGLT2 inhibitor, you see, it increases the glucagon level. But when combined with the DPP4, we can tackle that rise in glucagon. Next slide. So the other risk factor we are considering is CV risk and heart failure. So SGLT2 inhibitor, it is having a proven CV benefits like DAPA. And it is a preferred agent in patients, even with patients with heart failure. And DPP4, it is having proven safety. As example, sitagliptin in multiple comorbid conditions, even in hepatic patients also. So the reduction in risk factor and hospitalization due to heart failure is also less with DPP4. So when we are combining, this becomes a good fixed drug combination. So this combination becomes suitable combination therapy in patients with CV risk, even if they are having heart failure also. Next slide. So this was a study conducted in India with FDC of DAPA and SITA. So we can see day 1 and day 15. The results are quite impressive. This is average daily glucose. You can see, you can compare the reduction in average glucose. Daily FDC of DAPA and SITA significantly improves the glucose level at the end of 15 days. Next slide. So the optimum clinical approach to combination use of SGLT2 and DPP4. So based on glycemic factors, we can initiate with lifestyle modification. Then in treatment-naive patients, where metformin is contraindicated, usually we select metformin as the first. But in patients who are having issues with the metformin, or in patient with more than HbA1c more than 8, we don't give metformin initially in such patient. So these patients can be considered for starting FDC. Then in combination with metformin patients with baseline HbA1c is more than 9, in that patient also we can consider FDC. Then patients uncontrolled on metformin, with HbA1c more than 8.5, that also we can try SGLT2 and DPP4 FDC. Next slide. Uncontrolled on metformin plus second line, then we go on to the next level. We can add second line agents after that. Uncontrolled on metformin and second line agent except DPP4 and SGLT2. There also we can add additional drugs. We can add insulin if we are not getting good control with the second line drugs also. Next slide. This according to HbA1c criteria. SGLT2 inhibitors with proven CV and heart failure benefits are preferred agents in cases with cardiovascular disease, including heart failure. DPP4 inhibitors with proven CV and heart failure safety, such as linagliptin and sitagliptin, have shown a favorable CV safety profile, including no increased risk of hospitalization to heart failure in CVOTs. So this combination may be preferred over other conventional therapies, those with no CV benefits in cases of established CV disease and heart failure risk. You know, most of the majority of patients with diabetes, they are having this CV issues. They are having issues of subclinical heart failure. So this combination of SGLT2 and DPP4 can be used as a preferred agent. Next slide. So based on CKD, if the patient is having a comorbidity of CKD, then also we can use this combination. SGLT2 combination can be used when GFR is more than 45. SGLT2 with positive kidney outcome in CVOT should be preferred in kidney diseases. DPP4 also with proven kidney safety should be preferred in kidney diseases. So this combination of DAPA and SITA, which is a good agent considering the CKD issue also. Next slide. Especially when GFR is more than 45, we can safely use this. Then if you are considering weight loss issue, in the comorbidity, if the weight loss issue is to be given importance, then also we can use this combination of SGLT2 and DPP4. So SGLT2 promotes weight loss and DPP4 is weight neutral. So we can use this in obese patients. Next. So in the Indian setting, optical clinical approach to combination use of SGLT2 and DPP4, Indian phenotypes is characterized by increased visceral adiposity, lower metabolic tolerance, and increased cardio-renal risk. And it is important to address multiple aspects of underlying T2DM. Combination therapy with SGLT2 and DPP4 may be relevant in this regard. And this therapeutic combination may be pertinent partner to metformin. So if we are initially, if we are a patient is using metformin, then we can add this combination without increasing the risk of hypoglycemia. And this is very important. This risk of hypoglycemia, patients feel very comfortable when they are not getting episodes of hypoglycemia, and it improves the compliance. It improves the metabolic profile also. And the combination of agent with proven benefits may be preferred for other for the patient with a higher predisposition to CV events and kidney diseases in Indian setting. Next slide. So, in a nutshell, FDCs improve every key component of control. We have analyzed all the CV, we have analyzed the obesity part, we have analyzed the CKD part, we have analyzed the metabolic part. So all these issues, the SGLT2, DPPI, FDC gives a good performance, theoretically as well as in the practical. Next. This is simpler to use. Next. It is fewer stockouts, enhanced task sharing, lower pill burden, better control rate. So this combination will improve the compliance of the patient. Next slide. So thank you for your patient hearing. I think I have shed some light to the advances of the recent FDCs and the advantages if we are combining DPP4 and SGLT2. Thank you.
Thanks, sir, for your insightful presentation on this burning topic. So now the floor is open for any type of questions related with the topic. So sir is here. Take the advantage of sir. We will wait for 1-2 minutes, sir. Till now, we have not found any questions or raise hands. So
I think we have our slides are very comprehensive.
yes, sir. And with very big good clarity, sir. You have discussed all the points. I think no one is has any confusion related with the topic.
Yeah, this is a very combination with a very sound theoretical base, and we have shown that Indian study also. So this is a very good combination.
Yeah. So, sir, we will now call Mr. Ravi for vote of thanks. So, Mr. Ravi, over to you.
Yeah, thank you, Dr. Amajit. Before going to vote of thanks, I would like to share one very good news with all of you that we have Wosulin, and Wosulin has completed 20 successful years. Wockhardt Limited has launched Wosulin in year 2003. Before 2003, we were dependent on other countries like US and European countries for insulins. But after 2003, when Wockhardt launched Wosulin, we became the first Indian country, the first country in Asia to launch indigenous manufacturing of recombinant human insulins. Okay, so I would like to express my gratitude to all the medical fraternities and doctors to support continuously for last 20 years for Wosulin. thank you all the doctors. And coming to the vote of thanks, I would like to express my gratitude to Dr. Sajid NV for accepting our invitation to being a speaker on this iTrust webinar. Thank you, sir. And also, I would like to thank Dr. Amarjit Singh, Dr. Sanket Nevale, and Dr. Kunal also for their continuous guidance and coordination and providing the medical inputs and slides for this iTrust webinars. And the special thanks I would like to here to thank our IBB head, our president, Mr. Amrut Medekar sir, and our AVP, Mr. LCS Vishnu sir, for their continuous guidance and support for happening this smooth webinars every Saturdays. And also, I would like to thank all our HO colleagues who continuously, supported for these webinars, and the main heroes who are working behind the scenes, our field colleagues. We are continuously working for this, to continuously invite all the doctors and making this webinar successful. So thanks everyone, and thanks all the attendees and doctors who have attended this webinar today, iTrust webinar. And thank you, Dr. Sajid, once again. So we are closing the session now. Okay, and stay tuned. We'll be coming back very soon once again with some different topics.
I think there is one question. I think I just saw one. Sir, you can see the screen?
Yeah.
So this question on the screen.
Question.
Dr. Vilas Wada is asking question, sir. Does CETA causes pancreatitis? Does CETA causes pancreatitis?
Yeah, pancreatitis is one of the stated complications for CETA. This it's not very common to see pancreatitis with CETA. Initially, we need to screen the patient clinically also if patient is having risk factors for pancreatitis, then we need to be vigilant when we are giving CETA. But CETA as a molecule, practically we are not facing so much of issue with pancreatitis. It's a very, very safe drug. It has been studied in almost all the comorbid conditions, and it is found to be safe. Maybe there are incidences of pancreatitis, but we need to be vigilant when we are giving. This is for any drug. It is the same. No, when we are giving with adequate precautions. Just watch out for symptoms of pancreatitis. If the patient is having any abdominal issues, then we can detect it very easily. So that's not usually a practical issue. You are right. When in theory, it's right. It is written that it is causing pancreatitis. Yeah, because this is this incretin effect. No, it is having some stimulant effect on these pancreatic cells, and theoretically it can cause, but it's not really a practical issue when you are using the molecule.
Mr. Ravi, we had this question only.
Okay. Thanks, Dr. Sajid, once again. We are closing the session now, and thanks again, participant, once again. Thank you, all the attendees.
Thank you. Thank you, sir. Thank you, Dr. Sajid.
Oh, thank you. Thank you for the nice preparation for all these things.
Thank you, sir.
Thank you, sir. Have a nice day, sir.